Hi, this is Dr. Mirrafati from Mira Aesthetics. I've been told to basically describe or do a video distinguishing what's the difference with putting breast implant for breast augmentation versus fat transfer to the breast. So fat transfer to the breast, we started doing that when my office was in Newport Beach about 25 years ago. We did a bunch of them, and we actually wrote and published an article in the Journal of Cosmetic Surgery, and the title of the article was Bambi, B-A-M-B-I, Breast Augmentation Mammoplasty by Injection. And then we had pretty good results. Overall, it was satisfactory, but then there was a plastic surgeon up in somewhere in East, basically started criticizing putting fat in the breast and not being able to tell if the fatty necrosis calcification, which the fat particle basically become calcified, can be mistaken by calcification caused by breast cancer. So for a while was told to be below the standard of care to put fat in the breast, and sort of fell out of favor, and obviously people stopped doing them, and then implant was the way to go. And recently, the past few years, is a little uprise of the fat injection. But what I do notice, though, it is a little over abuse of what it does do. I think fat injection to the breast has its positive and negative, and is definitely patient selection is very, very important, and the patient should know what is my expected result. I see patient coming in here, and even on my website, they fill out the form and they're asking questions about breast augmentation via fat injection, which, by the way, if you guys want to do that too, you can go fill out the form, and then we send you a private link, and then I can take a look at your breast virtually, and at least, even if you're not coming here, give you my advice if you're a good candidate or a bad candidate. But wherever you decide to go, you should have a detailed discussion with your doctor about what is my positive and negative thing by putting fat in my breast versus just putting an implant. Because right now, with the route of axillary or umbilicus, where you're actually not cutting into your breast tissue, I don't want to say it's non-invasive, but it's probably as invasive as fat injection, and the downtime is really low, and obviously the pain level is also much lower because you're not cutting into your breast tissue. However, fat transfer to the breast by doing a breast augmentation mammoplasty, still a good route if it's patient selected and you're doing it for the right category of patients and they're told the negative side of it. For example, let's talk about positive stuff. The positive stuff for putting fat into the breast, but basically is you have no foreign body. There is no implant. There is no silicone, the saline implant to cause any of the stuff that happens when you place a foreign body into a breast, such as capsular contraction and hardening. They're not going to have any kind of basically implant disruption or a leakage of any material you put inside the implant, is it saline or silicone. I think the loss of sensation of doing a fat transfer is pretty much non-existent because you're really not cutting. However, also we have done over 8,000 augmentation via axillary. Knock on wood, I haven't had any sensation loss so far. So again, it's pretty rare with implant, but that is one of the positive side, that you basically not going to have that issue of having nipple sensation loss. So what are the negative side of it? Those are all sounds good. So I have patients coming in, they're really flat chested and they want to be a size D. That's not going to happen. Fat is a live object. And I tell patients there is only so much you can pump in. It's not like I can go to a person who has a flat chested area, go in there and inject 400 cc of fat. It's just not going to take. Fat need to have space in between it. So the blood supply can be picked up and fat can survive. So obviously, for somebody who's flat chested from size A, wanted to jump to size D, that's not going to happen. From at the best, it's going to be size A to size B. However, you could go back 6 months later when the fat is already taken and take some more fat, put it in, but obviously the cost factor of it is there as well too. And you can gradually increase that breast over the years, over many procedures that can be done. Remember, when you do fat transfer to the buttocks is a large area. Breast is not a whole lot of area, so you can't just go compact fat in there. You need space between the fat molecule that you're putting in for it to pick up blood supply. You can't just slam pack it against each other and cause it to all of it actually die away. And another downside to it still is the fact that there is a still, in my practice, if there is a family history of breast cancer in the family, the immediate family, sister, mom, I sort of shy away from it, even though it has been proven that the calcification of the fat itself is way different than the calcification of what breast cancer calcification is. Breast cancer is more specule, fat transfer calcification is very round. So I think the radiologists in California, Miami, Florida, areas that there's a lot of breast implant done, people can distinguish fatty calcification from basically calcification caused by breast cancer. But there's that doubt still there. So if you have calcification in anybody's mind, okay, could it be a breast cancer or not? So if you have a family history of immediate family of breast cancer, I shy away from putting fat into the breast. Another factor is if you drop. That's one of the common thing. I have a lot of Hispanic patients. They come in, their breast is a little drop, and they've been told, oh, I can put fat in there. Well, think about it. Your breast is over here. Obviously, you can do it by lowering the fold and putting an implant to evert it without lifting, which I can do another video just on that. But basically, in your scenario, you're going to put fat right up here and nothing here. If you do it more here, it's going to basically cause it to be more heavy and drop. So you end up doing in the superior pole of the breast. Now you sort of have a lump of breast here and a lump of breast down here. It just looks terrible. So I do not do it for people who are orthotic or breast, or they have a very loose down orthotic breast. I generally shy away from those as well. As I said, it works great for patients who are flat chested or maybe size B and they want to go one cup side. It's a beautiful thing to do, but you need to be very cautious of selecting the right patient. And more importantly, the patient should know the outcome of the result, not to expect that you're going to go in, boom, I'm going to come out and I'm going to put an implant. And also the cost wise, some of the people think, oh, it's a great idea. I just basically take my fat out of here, put in my breast. So I do a lipo and breast. Again, I did a video on this on BBL or Brazilian, which I was asked to clarify that, which I will probably get to it in a future video. You never want to do a lipo fat into the breast. Liposuction by definition is lipodystrophy, which means you are destroying the fat cells. You never want to go in there, get that lipo fat and inject it into the breast, because all you're doing is injecting oil. First of all, none of it's going to take anyway because they're not an intact fat cell. Second of all, it's dangerous. You're basically injecting a whole bunch of oil into the very compact, very very circulated area. That's a no-no. So what you need to do, you need to do fat harvesting, which is a different apparatus of fat, lower basically pressure, maybe just use a hand syringe cannula to get the fat, clean the fat, make sure all the fat particles are good and intact, and then you want to do fat from the harvested fat, not the lipo fat. and inject it into the breast tissue. Again, it's not the fact, oh, I'm going to get a trimmer waist on my belly is going to be flat and my breast is going to go higher. That is not going to happen. And unfortunately, I hear this from patients all the time. The doctor so-and-so did this. Again, wherever you decide to go, ask your surgeon, how are you getting the fat? Are you lipoing it? If they actually promise the fat, oh, you're going to be flat in here, that is sign of a dead giveaway that maybe you should consult more physician about your procedure. I wouldn't just, because just by definition, it doesn't make sense. You don't want to lipo and put that lipo fat into the breast. You want to do fat harvesting. So, you got to be able to determine that the fat you're putting in to begin with is a wholesome fat, is a fat that is not denatured, it's a fat that is a cellular membrane is not all disrupted, is an intact fat. So it could have highest chance of picking up blood supply and survive. So in summary, patient selection is important, the size is important, and make sure that you understand everything that they explain to you. Remember, if you go for a consultation, that your surgeon should be able to explain everything to you in a layman language that you could understand. If it's a lot of technical word used, that's probably indication that they don't even know what they're talking about. So ask questions, and ask to see photos. Make sure the photos are the same light and the same angle. It's not like one is without a light, the other one light shines right onto the breast. You want to have the same setup for the photo. Like in our practice, we actually have a photo room. So preoperatively, the same light, the same camera picture is taken. Postoperatively, the same light, the same camera is taken. So that way you're being honest with your result. So have a beautiful rest of the day. And if you have any question, you can just basically send a little comment, and I try to get to all my questions as soon as I can. Have a good day.